At the outset, I would like to thank the organizers for the invitation to speak on eosinophilic gastroenteritis. Over the course of next 20 minutes, I try to cover both eosinophilic gastroenteritis and esophagitis. So, whenever we talk about eosinophils, we tend to think about parasites. And whenever the question is about gastrointestinal eosinophilia, apart from parasites, other things which must come to mind are other infections like spirochetosis, drug-induced eosinophilia, eosinophilia as part of hypereosinophilic syndrome, which may accompany certain hematological malignancies, or associated with autoimmune diseases like Churg-Strauss syndrome, and then underlying GI diseases which may be associated with increased eosinophils like celiac disease or inflammatory bowel disease. Now, the diagnosis of eosinophilic gastrointestinal disorders is to be made only in the presence of gastrointestinal symptoms apart from presence of eosinophils in the gastrointestinal tract. And this is only after recognized causes of eosinophilia have been excluded, like the ones we have already talked about. So, eosinophilic GI disorders is a spectrum of many diseases, and these may include the eosinophilic esophagitis, gastritis, the involvement of the small bowel, or the colon. Now, the term gastroenteritis is usually referred to for gastritis and enteritis, but it must involve at least two segments of the GI tract. Esophagitis is not usually included in this particular terminology. Now, some parts of the bowel do have eosinophils normally. In fact, most of the bowel does have a few eosinophils, except for esophagus, where eosinophils are abnormal. And the numbers keep increasing till around the terminal ileum and the cecum and the right colon, and after which, again, there is a decline in number of eosinophils. And that is the reason that the cutoffs which are used for diagnosis of eosinophilic disorders of a particular area or region are variable. So for esophagitis, it is usually a number of more than 15 per high power field. For gastritis, it is more than 30. For enteritis, it is more than 50. And for colon, it is usually variable for various sites, more for right colon and less for left colon, but has to be more than 25 per high power field. Now, there are a few differences between eosinophilic esophagitis and gastroenteritis. Esophagitis is primarily recognized as a mucosal disease, but we know that gastroenteritis could involve the mucosa or the muscularis or even the serosa. Now, the counts for diagnosis for esophagitis are pretty certain. More than 15 is consistent with eosinophilic esophagitis, but not so for gastroenteritis. And in fact, they are variable, and there is a lot of debate about the actual cutoffs. Then peripheral eosinophilia is very frequent with eosinophilic gastroenteritis, but may not be very frequent with eosinophilic esophagitis. And of course, for treatment, PPIs are one of the agents of choice for eosinophilic esophagitis, but not so for gastroenteritis. So the clinical presentation of eosinophilic gastroenteritis depends upon at least two components. What is the site of involvement? Stomach, small bowel or colon, or the esophagus. And of course, the part of the bowel which is involved, whether it is mucosa, whether it's muscularis or the serosa. So depending upon the site of involvement of the bowel wall, so for mucosal involvement, it could present with pain, but also with diarrhea, including bloody diarrhea. And there may be features of malabsorption, including iron deficiency or protein-inducing enteropathy, and failure to thrive could be one of the presentation in childhood. Muscular involvement is usually associated with obstructive symptoms, and the serosal involvement may present with exudative eosinophil-rich ascites. Now, coming to the clinical spectrum, and these are two studies from the same center in the United States which looked at data on eosinophilic gastroenteritis. And if you see that in 1990, the published report, which included patients over the previous 4 decades, showed that around 57% had mucosal involvement and 30% had muscular involvement, around 12% with serosal involvement. But in the data which was reported in 2010 of the patients seen subsequently, a large fraction had mucosal involvement. Now, this may be because of the increase in access to endoscopy and increase in endoscopic biopsies that the mucosal form is recognized as a much more frequent variant of eosinophilic gastroenteritis. The endoscopic findings are many, they're variable, and not really specific. So you could have thickened folds, ulcers, nodularity, whitish specks, which could be consistent with underlying eosinophilic abscesses, then capsule images showing stricture, aphthous ulcers, especially with cow milk protein allergy in infancy. So a large spectrum of endoscopic findings are recognized to occur with eosinophilic disorders. Similarly, the radiologic features are also not very specific. They may merely represent the thickening of the bowel or destruction of a part of the layer of some of the layers of the bowel, or strictures which might have developed because of the disease. Some of the signs have been described with the eosinophilic gastroenteritis, and here you can see thickening of the colonic mucosa, and then this aranid limb-like sign, which is similar to the accordion sign reported in inflammatory colitis. Then this is another patient we saw with eosinophilic ascites, long-standing ascites, and then you can see mural stratification of the bowel loops, including the cecum and ascites here. So very, very variable radiological presentations. And then there are site-specific differential diagnosis. Apart from, of course, the differential diagnosis you routinely consider for eosinophilia, for gastritis, Helicobacter pylori, or drugs like NSAIDs and mycophenolate mofetil. For duodenal eosinophilia, must exclude underlying celiac disease or functional dyspepsia, especially the postprandial distress type, which may be associated with eosinophilia. For colonic involvement, one must rule out strong amyloidosis or parasitic infections and cow milk protein allergy in the relevant age group. So, how to make a positive diagnosis? Very important to read through the pathology reports, because the pathologist may report the eosinophils, but they may not count and they may not mention it as a differential diagnosis. When one finds eosinophilia, one must deworm the patient, look at the clinical setting, look at what else any drugs could have caused eosinophilia. Are there other causes which can explain eosinophilia? Repeat the endoscopy if possible. Do systematic biopsies for colon, segmental biopsies as one would do for inflammatory bowel disease. For stomach, use the Sydney protocol. For duodenum, 4 biopsies from the first and the second part, and from esophagus, from all areas of the esophagus. Also rule out other causes. Do a stool examination, colon fluid microscopy for protozoa, and serum tests to rule out infection. Pathologists should also look for parasites, spirochetes, and strongyloidosis in the biopsies which are available. Now, once you have excluded these things and you're pretty certain that the underlying diagnosis is of a eosinophilic gastrointestinal disorder, what is the line of management? The first line of therapy is dietary therapy. And what has been seen is that there may not be much role for targeted diet, which is chosen on basis of allergy tests. Rather, 4 food or a 6 food elimination diet could be a good initial therapy. And elemental diet virtually succeeds in most of the patients, although it is difficult to administer. So the approach is, once a diagnosis and exclusion of other causes is done, there's no underlying surgical issue like obstruction or perforation, then dietary therapy should be tried. If there is a response, one could monitor and maintain on some dietary modifications. If there's no response, the second line of therapy is oral steroids. And once these are tapered, there may be a need to, have a maintenance therapy. In patients who don't respond, then other therapies are primarily, I would say, experimental, but there is some evidence of benefit with anti-IgE antibody. Uh, so, what is the natural history of eosinophilic gastroenteritis? So, in a median follow-up of 13 years, 42% patients did not have relapse. 37 had a chronic, 20% had a chronic disease, and 37% had a relapsing remitting course. Now, in patients after 1 year after stopping steroids, you can see that around 45% had some form of relapse. Now, we'll briefly also talk about eosinophilic esophagitis, which we are much more likely to encounter in clinical practice. So, apart from the secondary causes of eosinophilia in the esophagus, which we have already talked about, the primary eosinophilia could be associated with atopy or may not be associated with atopy, but a small number could be having a syndromic diagnosis like Ehlers-Danlos or some familial form of eosinophilia. Now, the spectrum of clinical presentation is variable with the age. For infants and toddlers, usually it is the feeding dysfunction, which is the presentation. For school going, it is vomiting, abdominal pain, and in adolescents and adults, it is dysphagia and food impaction. So this merely indicates how the spectrum of the disease shifts from inflammatory to fibrostenotic with time. Now, for endoscopic assessment, there is a score, the eosinophilic esophagitis endoscopic reference score, which has major and minor criteria. And the major criteria include edema, fixed rings, exudates, furrows or strictures, and the minor crepe paper esophagus is recognized as one of the criteria. So here you can see that these are fixed kind of rings, also called as trachealization or corrugated appearance of the esophagus. And they may become severe, so much so that even the endoscope may not be passable. So this is how this particular factor is scored. Then you could have exudates. Again, these are white lesions which may occupy variable amount of surface of the esophagus, and the scoring is dependent upon the amount of surface which is involved. Now, there could be furrows, which are vertical lines. You can see here vertical lines. Again, they may have a visible depth or they may not have. But if there is an indentation, it may suggest a more severe kind of involvement. Now, there could be esophageal edema when the usual vascular pattern may not be as well visible or may disappear completely. And crepe paper esophagus, which suggests mucosal fragility with the passage of a scope, and this is not with dilatation, only with passage of scope. If such kind of trauma is seen, then that's a crepe paper esophagus. Other findings could be feline esophagus or the transient esophageal rings which disappear with distension with the air. So this is one of the findings which can be part of the eosinophilic esophagitis, and then there could be a narrow caliber esophagus when one cannot pass the scope. Certain new findings have also been recognized. So there is a biopsy pull sign where it is difficult to close the biopsy forceps completely, and when an attempt to take a biopsy is made, there is some resistance to taking the biopsy. So this is the pull sign, which has been described as a feature of eosinophilic esophagitis. None of these is very, very specific. Now, the important differential diagnosis is, of course, reflux disease and eosinophils, especially in the lower esophagus. may be part of reflux disease. But for eosinophilic esophagitis, the eosinophils would involve almost the entire esophagus, including the upper and middle part, and the eosinophil count will be much more, usually more than 15 per high power field. The eotaxin levels are elevated in eosinophilic esophagitis, and the epithelial hyperplasia is much more prominent. So these are some of the features which pathologists may use to differentiate eosinophilic esophagitis and GERD. Now these are just representative images of eosinophilic esophagitis here, a large number of eosinophils and very small number of occasional eosinophils in the gastric, in the reflux disease. Now, coming to allergic testing, although many people perform allergic testing, including skin prick tests and the serum IG testing, but as of today, there is no clear evidence of benefit of this particular approach in management of these patients, because there is no data to suggest that there is any additional benefit of a diet which is based on testing vis-a-vis the standard elimination diet. So treatment includes changes to the diet, and in fact, the elemental diet has excellent results for management of eosinophilic esophagitis. Elimination diet is more acceptable for the patient and easier to administer than the elemental diet. Then many people are not really interested in taking diet over long term. So drugs could be the initial therapy of choice. Proton pump inhibitors, there are a subset of patients who respond very well to this. And in fact, earlier, there was a PPI responsive eosinophilia, which was thought to be distinctive from eosinophilic esophagitis, although now it is very well recognized to be part of eosinophilic esophagitis. And of course, the other drugs are the topical steroids. Biologics, some of them have failed trials, but there is some upcoming evidence for some of these drugs. And then dilatation only if it is needed, and it has to be a graded approach because the initial report suggested that there may be an increased risk of perforation. So steroids, topical steroids, budesonide and fluticasone are the drugs which could be used either as form of viscous slurry, suspension, oral disintegrating tablets, or swallowed puffs from the inhalers. Now, systemic steroids, there's just a single randomized trial comparing them to topical steroids, and in fact did not show much additional efficacy, and therefore topical steroids are the standard of care. Now, there are certain additional therapies which have been tested and not really effective: anti-TNFs, anti-IL-5, anti-IgE. But there is some evidence of benefit with the anti-IL-13 and IL-4, and these are the drugs people are looking forward to for treatment of resistant cases. So dilatation is never a standalone therapy, only to tide over the acute symptoms, because the inflammation which incites the fibrosis also has to be treated. So symptomatic improvement is common with dilatation, and pain is very, very common. So almost 3/4 of the patient will have some amount of pain. Follow-up is usually with symptoms, but must also include endoscopy and documentation of histologic response. In the future, there may be an upcoming role for string tests or cytosponge, but as of today, it is endoscopy with biopsies to document histologic remission. So how do you approach these patients? If there is evidence of eosinophilic dysfunction, esophageal dysfunction, and endoscopic findings are either suggestive or consistent, but they may be normal also. There is histology which suggests eosinophilia, other causes are excluded. If there is a symptomatic stricture, dilatation. If not, then first line of therapy, depending upon patient choice, it could be elimination diet, PPI, or topical steroids. If there is a response, you continue with maintenance therapy. If not, second line therapy. One of these could be the second line therapy. So to summarize, eosinophilic gastrointestinal disorders, although not very common, are increasingly being recognized, and including in India, and there is a report from AIMS about it in patients of GERD. Eosinophilic gastroenteritis may be less common than esophagitis. The diagnosis is of exclusion, must exclude other causes of eosinophilia, and important to consider in patients who are symptomatic. Subset of eosinophilic esophagitis are PPI responsive. Diet and steroids play an important role in therapy. For esophagitis, PPI and topical steroids are additional options, and maintenance therapy would be needed for most of these patients. Thank you for your attention.